Here is a number that should bother you. The average Medicare patient appointment in the United States lasts 11 minutes. Not 20, not 15, 11. And inside those 11 minutes, a doctor is expected to review your chart, address your concerns, manage your medications, and make clinical decisions that affect your heart, your blood pressure, your nervous system, and your long-term quality of life. Now here is what nobody tells you about those 11 minutes. Most seniors leave the exam room having said less than half of what they actually came in to say, not because they forgot, because something happened in that room that made them feel like they were taking too long, like they were being a burden, like the doctor was already thinking about the next patient before they finished their sentence. I am going to show you exactly what that looks like, why it is genuinely dangerous for adults over 60, and what you can say word for word to stop it from happening to you again. Stay with me through all 5 of these, because the last one is the one that most people have never heard named, and once you hear it, you will recognize it every single time. My name is Dr. Thomas. I am a specialist in cardiovascular health and aging, and in my work with adults over 60, the pattern I keep seeing is this: the most dangerous moment in a senior's healthcare is not the diagnosis. It is the appointment where the full picture never gets communicated, where something important goes unsaid. And the reason it goes unsaid is almost never the patient's fault. Let me tell you what that actually feels like from inside the room. You have been waiting 3 weeks for this appointment. You wrote down 4 things on the back of an envelope on your kitchen counter. You got dressed, you drove over, you sat in a waiting room for 35 minutes past your scheduled time. By the time the doctor walks in, you are already slightly on edge, slightly apologetic for existing. And then the doctor comes in moving fast, standing, not sitting, and somewhere in the first 60 seconds of that interaction, you get a feeling. A specific feeling that most people over 60 recognize, but almost nobody talks about out loud. The feeling that you are going to have to wrap this up. That feeling is not in your head. It is being communicated to you through very real physical and behavioral signals. And the reason it matters for your cardiovascular health specifically is this: chronic stress, even the low-grade kind produced by a rushed and unsatisfying medical appointment, activates your sympathetic nervous system. It raises cortisol. In adults over 60 whose circulatory systems are already managing changes in arterial flexibility, elevated cortisol after a medical appointment is the last thing you need. And the clinical information that went unsaid during that appointment, that is what leads to the preventable hospitalizations. There is real hope in this though, because every single one of these 5 red flags has a response. A specific thing you can say that resets the dynamic without being rude, without being confrontational, and without burning your relationship with your provider. You have the right to your full appointment. You paid for it with decades of Medicare contributions. Let's make sure you know how to use it. Let's start with number 5. Number 5 is one most people notice but cannot quite name. You have seen this happen. The doctor walks into the exam room, and something about the way they enter tells you, before they have said a single word, exactly how long this is going to take. They do not pull up a chair. Their body is angled slightly toward the door. One hand might be resting on the edge of the counter, and then, right in the middle of you explaining your symptoms, the hand moves, it finds the doorknob. This is called the hand on the doorknob exit, and it is one of the most well-documented forms of nonverbal pressure in medical communication research. What it does to a patient is not subtle. That small gesture, a hand on a doorknob while you are still talking, creates a measurable increase in psychological pressure to stop speaking, to summarize, to cut yourself short. And for adults over 60 who often feel like they do not want to be a bother, that pressure works. The danger here is specific. The thing a senior decides not to say in that moment, because they feel the clock running out, is often the most clinically important piece of information in the room. A new pain they noticed 2 weeks ago. A side effect they have been experiencing but were not sure was worth mentioning. A symptom they dismissed but that a cardiologist would recognize immediately as a flag. I had a patient named Gerald, 68, retired postal worker from Columbus, Ohio. Gerald came in for a routine blood pressure follow-up. His doctor was pleasant, not unkind, but Gerald noticed about 4 minutes into the visit that his doctor was already beginning to wrap up. Gerald had one more thing he wanted to mention, a tightness he had been feeling in his upper back, usually in the morning, usually after his first cup of coffee, not chest pain. He decided not to bring it up because the doctor seemed ready to move on. Gerald mentioned it to me 3 months later when his wife insisted he get a second opinion. That upper back tightness, combined with his blood pressure history and a couple of other factors, sent me straight to a cardiac workup. What we found changed his treatment plan entirely. Gerald told me afterward, and I am quoting him directly here, "I thought I was just being a hypochondriac. I didn't realize I had the right to finish my sentence. If you see a hand on that doorknob, here is exactly what you say. You say, 'Doctor, before you leave, I have 2 more specific medical concerns I need documented in my chart today.' Not questions. Concerns. Documented. Those 2 words tell your doctor that you are not looking for reassurance. You are creating a paper trail. That changes the entire dynamic, politely and professionally, in about 4 seconds. Number 4 is about what your doctor is looking at instead of looking at you, and why that gap is costing seniors real clinical information every single day. Here is something that most patients do not know. The Electronic Health Record System, the EHR, was designed to improve care coordination. What it actually did in many practices is create a situation where the doctor's eyes are on a screen for the majority of a brief appointment, typing, clicking checkboxes, navigating drop-down menus. And while that is happening, the patient is talking to the back of someone's head. The problem this creates is not just about feeling heard. It is about what gets missed visually. A doctor watching a patient speak can observe an enormous amount of clinical information: a slight tremor in the hand, asymmetry in the face, the way a patient winces when they shift their weight, pallor, the subtle physical signs that show up long before they show up on a blood panel. None of that is observable when the doctor's eyes are on a screen. This is one area where you have direct control over the interaction. If you are more than 30 seconds into explaining a symptom and the doctor has not made eye contact, you do not need to raise your voice or repeat yourself. You pause. You simply stop talking. Most physicians, when they hear silence, will look up. And if they do not, you have the right to say, "I want to make sure you can see what I'm describing here. Can we look at this together for a moment?" This is not confrontational. It is actually a clinical invitation, and any physician who responds negatively to that is giving you information you need to have. Number 3 involves a specific number from a study that most people never hear, and once you do, you will think about it every single time you walk into an exam room. On average, doctors interrupt a patient within 18 to 23 seconds of them beginning to explain their symptoms. 18 seconds. That is not a rumor. That comes from a study published in the Journal of General Internal Medicine, and the number has held up across multiple replications. For a rushed appointment, that interruption usually sounds like a jump to conclusion. You start to describe your symptoms and the doctor says, "That sounds like it could be X," before you have given them the full picture. Now the visit is organized around that early conclusion, and everything you say afterward is filtered through it. Here is why this is specifically dangerous after 60. Symptom presentations in older adults are frequently atypical. The classic presentation of a cardiovascular event that every medical student memorizes does not always look the same in a 68-year-old woman as it does in a 45-year-old man. Nuance matters. Context matters. The second and third symptoms you are about to mention matter. And if the doctor cuts you off after the first one, the context never gets built. The move here is simple and requires no confrontation. When you get interrupted, you let the doctor finish their thought. You do not argue with their early assessment. And then you say, "I understand that part, but I need to finish explaining the rest of the symptoms so you have the whole picture." The whole picture. Use that phrase, because it frames your remaining information not as pushback but as clinical contribution. You are helping them do their job. Number 2 involves your medications, and it is the one that has the most direct connection to hospitalizations in adults over 60, which is why I put it this high on the list. Most seniors over 60 are managing more than one prescription. Many are managing 4 or 5. When a doctor rushes an appointment and something in your treatment plan is not working as expected, the fast solution is to add something new or change a dosage. Write a prescription. Send it to the pharmacy. Move on. What that does not involve in a rushed visit is a careful review of what happens when that new prescription meets everything else already in your system. Polypharmacy is the clinical term for managing multiple medications simultaneously, and in adults over 60, it is one of the leading contributors to preventable emergency room visits in this country. The interactions are not always obvious. They are not always on the label. And a physician who is working against a clock is far less likely to pull up the full drug interaction profile in front of you and walk through it. Do not leave your chair. I mean that literally until you have asked one specific question. You say, "What are the specific side effects of this change, and how will it interact with my current medication list?" Not your maintenance medications, your current medication list. Every single thing you are taking. If the doctor cannot answer that question in the room, that is information. That is important information. I will tell you about a patient named Marlene, 71, retired school teacher from Baton Rouge. Marlene had been managing a heart rhythm issue for about 2 years. At a routine follow-up, her doctor adjusted one of her prescriptions, a straightforward change, handled quickly, explained in about 45 seconds. Marlene left the office with the new prescription and a general feeling that everything was fine. She ended up in the ER 11 days later with symptoms that, when we traced them back, were a direct result of how that new medication was interacting with a supplement she had been taking for joint pain. A supplement she mentioned to her doctor. A supplement that was not reviewed against the new prescription before it was prescribed. Marlene told me, "I didn't know I was supposed to ask. I thought he was taking care of that part." She is not alone. Ask the question. Every time. Without exception. And number 1, the red flag most seniors never think to look for because it happens at the very end of the appointment when your guard is down and you are already reaching for your coat. Here is what a proper appointment close looks like. Before leaving the room, the physician confirms that you understand your diagnostic plan. They tell you what tests are being ordered and why. They explain what results will trigger what next steps. They verify by asking you to repeat it back, that the instructions for any new medication are clear. They give you a follow-up timeline that is specific, not vague. That kind of close takes about 3 minutes. In a rushed appointment, it does not happen. What happens instead is that the doctor leaves and a nurse hands you a printout at checkout, maybe a summary from the EHR, maybe a pharmacy send, and you walk to your car holding a piece of paper that answers about 40% of your questions. The danger here is what happens at home. Seniors who leave an appointment without a clear understanding of their care plan make errors. They take the new medication at the wrong time. They discontinue the old one too early or not at all. They miss the follow-up window because the timeline was never made concrete. They do not schedule the scan because nobody confirmed it was urgent. These are not forgetfulness errors. They are communication failures that occur inside the exam room and then play out in the kitchen, at the medicine cabinet, at the pharmacy counter. The tool for this is called TeachBack, and you do not need to wait for the doctor to use it. You use it yourself. Before the doctor is fully out of the room, you say, "Just to verify I have this right, I am stopping pill A, starting pill B, and scheduling the scan for next Tuesday. Is that correct?" What that does is 3 things simultaneously. It forces a confirmation, it creates accountability. And if you have something wrong, it corrects it right there in the room before the consequences play out at home. Nurses are excellent. Printouts are helpful. But the physician is the one who made the clinical decision, and the physician is the one who needs to confirm that you understood it. If you found yourself nodding at more than 2 of those, the rushed exit, the screen-locked doctor, the interrupted explanation, the quick prescription change, the abrupt close with no confirmation, I want you to do something right now before you even click away from this video. I want you to think about your last 3 appointments and honestly ask yourself how many of those 5 were present. Here is what I want you to type in the comments below. Tell me which of these 5 you have personally experienced and whether you said anything about it in the moment. I read every one of these, and what you share down there actually helps shape what we cover next, because your experience is not unique. It is representative of millions of seniors navigating the exact same system. Now here is what I want you to watch for after you start using these responses. In the first appointment or 2, you may feel some discomfort. Saying, "I need to finish explaining the rest of my symptoms so you have the whole picture," feels unnatural if you have spent decades being deferential in exam rooms. That discomfort is normal, and it fades quickly. By your 3rd or 4th appointment using these phrases, something shifts. The visit starts to run differently. The doctor, consciously or not, adjusts. The dynamic begins to change because you have communicated, clearly and without confrontation, that you are an informed and engaged participant in your own care, not a passive recipient of it. Your cardiovascular health, your medication safety, and your ability to catch something early enough to matter. All of it depends on what gets communicated in that room. Not what you thought about on the drive home, not what you meant to say. What actually gets said, acknowledged and documented. There is someone in your life, maybe your spouse, maybe a sibling, maybe an adult child, who has been trying to get their parent to speak up at doctor appointments for years, who needs to see this video. You know exactly who I am thinking of. Send it to them today. And if you found this useful, I want you to subscribe before you go, because next week I am covering something that connects directly to what we talked about today. We are going to look at the specific questions to bring to a cardiac screening appointment, the ones that most adults over 60 never think to ask, but that can catch arterial changes years before they become an event. If you are managing blood pressure, if you have a family history, or if you are just past 60 and taking your heart health seriously, that video is one you do not want to miss in your feed. Here is your 30-day challenge, and I want you to take it seriously. Before your next appointment, whether that is in 2 weeks or 2 months. Write down your 3 most important health concerns on a piece of paper, not a phone note. Paper. Carry it into the exam room. If the appointment starts to run short before you have addressed all 3, pull out that paper and say, I have 3 concerns I need to document in my chart today, and I have them written down right here. That single action, written, specific, stated early, changes the appointment. It communicates to your physician that you came prepared. It tells them you intend to cover what you came to cover. And it protects you in the most practical and immediate way from the thing we talked about today. Do that for the next 30 days of appointments, and I will tell you exactly what to expect. You will leave the office feeling like you were actually heard. That feeling after decades of 11-minute appointments is something you have earned the right to feel every single time.